right, so we're diving deep today, folks, into orbital cellulitis.
Oh, yeah.
And I know this is a big one for all you ophthalmology folks out there.
It is.
Especially,
Yeah.
gearing up for those oral exams, right?
Really.
We're going to tackle a simulated patient case,
Okay.
walk through some of those differential diagnoses.
Sure.
And really focus on those key management strategies you absolutely have to know.
Love it. Let's do it.
So by the end of this, you'll be ready to handle any orbital cellulitis question they throw at you. No sweat.
That's the goal.
Okay.
And, it's a condition that deserves that level of prep. We're talking about a potentially vision-threatening infection here.
Yeah.
It involves the soft tissues behind that orbital septum.
The orbital septum. Can you remind us, what is that exactly? I always get a little fuzzy on the anatomy sometimes.
Right. So think of it as like a fibrous wall between the front of your eye and all those deeper structures in the orbit.
Okay, makes sense. So it's like a barrier protecting the eyeball, basically.
Yeah. Exactly. Now, when an infection gets past that barrier into those deeper tissues, that's when you've got orbital cellulitis on your hands.
And that's when things get serious. It's not just your typical pink eye.
Definitely not. This can spread quickly and cause some major complications. Speaking of which, let's jump right into a case, see if you can pick up on some of those telltale signs. Picture this. You're in the ER.
Okay. Oh boy, here we go.
Worried parent brings in their 7-year-old, and the child's left eye, it's just massively swollen and red.
Jeez.
And not just swollen, it's actually bulging outwards, like...
Oh, wow. Proptosis.
Proptosis, right.
That's like bulging eye, right?
Exactly.
Yeah.
And it makes sense. You've got all this inflammation fluid building up behind the eye, pushing it forward.
Okay, that makes sense. And you also mentioned the child was in pain, especially with eye movement. So they're probably having trouble looking around, right?
Yeah, that limited eye movement. That's another classic sign. The inflamed tissues are basically restricting those extraocular muscles, the ones that control eye movement.
Right. And to make matters worse, let's say a CT scan shows a soft tissue mass. It's tucked in there between the left lamina pepparacea and the left medial rectus muscle.
Oh, that's not good.
So what are your initial thoughts here? What diagnoses are popping into your head?
Okay, so given this whole picture, a few things spring to mind immediately. First, you always got to consider preseptal cellulitis, especially in a kid.
Right.
Much more common, less serious. It affects those tissues in front of the orbital septum.
Okay.
But we can't rule out other things like tumors. Got to think about that, especially in this age group.
Sure.
But considering the severity of the swelling and what we're seeing on the CT, orbital cellulitis has got to be at the top of our list.
Okay, that makes sense. But how do we really nail down the difference between preseptal cellulitis and orbital cellulitis, clinch the diagnosis? What would you be looking for in this particular case?
All right, so this is where those key clinical features we talked about really come into play.
Okay.
One of your sources actually has a really handy table comparing the two.
Perfect.
Preseptal cellulitis, it's usually just eyelid swelling redness. You wouldn't see that proptosis,
right?
The pain with eye movement or those limitations in eye movement like we have here. And then on top of that, those CT findings, especially that soft tissue mass, it's screaming orbital cellulitis.
It does sound like all signs point to orbital cellulitis.
It does.
And this is a serious situation, right?
Oh, absolutely.
What are the absolute must-do steps we need to take right now?
This is where you got to act fast.
Okay.
First things first, this child needs to be admitted.
Straight to the hospital.
No messing around.
Wow. Okay. So what happens next?
We got to hit this infection hard.
Okay.
And that means broad spectrum IV antibiotics.
IV antibiotics. Okay. Now remind me, what were those common bacteria that usually cause this? You mentioned them earlier.
Right. Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenza. Those are the big ones.
Got it.
And since we don't have culture results yet to tell us exactly what we're dealing with, we got to cover all our bases.
Makes sense. So what specific antibiotics would you recommend in this case? I know the sources mentioned a few different options.
Yeah, so one of your sources suggests intravenous cefuroxime.
Okay.
Good choice for both kids and adults.
All right, and what about the dosage?
So for a child, you're looking at around 750 milligrams to 1.5 grams, given 3 times a day.
Okay.
Adults, typically 1.5 grams, also 3 times a day.
Got it. So we've got the child admitted, started on IV antibiotics.
Yeah.
What else is on our to-do list?
Monitoring. Close monitoring is key.
Okay, monitor what specifically?
Visual acuity, for sure. You want to keep a close eye on that,
Mhm.
their extraocular motility and how
Yeah.
their optic nerve is functioning.
So basically, we're looking for any changes that could mean the infection is getting worse or the complications are developing, right?
You got it.
And speaking of complications, that's what really worries me with orbital cellulitis. Like, what's the worst that could happen here? What are the real scary scenarios?
That's a smart question, and it's something you definitely want to be prepared to discuss in your exam because, trust me, orbital cellulitis can have some devastating consequences.
Oh, I believe it.
If it's not managed properly, it can spread beyond the orbit, potentially leading to intracranial complications.
Intracranial.
We're talking meningitis, even brain abscesses.
Oh, wow. That's terrifying.
Those are incredibly serious, and they can absolutely be life-threatening.
And what about vision loss? Is that a real risk in these cases?
Unfortunately, yes. The infection can directly impact the optic nerve, which, it transmits those visual signals from the eye to the brain.
Great.
So if the optic nerve gets compressed or damaged by the infection, vision loss is a real possibility, and sometimes it's permanent.
So monitoring the optic nerve, that's absolutely critical.
Absolutely. And one of the sources mentioned checking optic nerve function every 4 days.
Every 4 days. Okay, so why is that so important? Like, what are we actually looking for when we do that check?
So the goal is to catch any signs of trouble early.
Okay.
We're going to be checking their visual acuity, their color vision, how their pupils are responding, and we'll be looking at the optic nerve itself with an ophthalmoscope, getting a good look.
And what exactly are we looking for on the optic nerve? Like, what are the red flags?
So any decrease in their visual acuity, changes in their color vision, if their pupils aren't responding normally.
Got it.
And then when we look with the ophthalmoscope, we're looking for any swelling or pallor of the optic disc.
Okay.
Those are all signs that the optic nerve is in trouble and we need to act fast.
Makes sense. So it's not just about treating the infection, it's about protecting the eye and preserving vision.
Exactly. It's a multi-pronged approach.
Now, speaking of treating the infection, you mentioned imaging earlier, specifically a CT scan.
Right.
What role does that play in managing orbital cellulitis?
Imaging, particularly that CT scan, it's absolutely essential.
Okay.
Gives us that clear picture of what's going on inside the orbit.
So what are we looking for on that CT scan?
Well, we're looking for any signs of inflammation in those orbital tissues.
Like what? Give me an example.
So you might see what's called soft tissue stranding or edema.
Mm-hmm.
Also, any collections of fluid, that could be a sign of an abscess.
Oh, an abscess. Okay, so like a superior abscess. One of the sources mentioned those.
Exactly.
What's so important about those? Why do those worry us?
Well, for one, they're a pretty common complication of orbital cellulitis.
Oh, really?
And they can cause a lot of trouble. They can press on the optic nerve, and that can lead to vision loss.
Oh.
And they can erode into the surrounding bone or even spread to other areas like the brain.
Yikes. So if we spot a superior abscess on the CT scan, that changes our game plan.
Absolutely. If we see that, it usually means we're heading to surgery to drain it.
Okay. To relieve the pressure and stop it from spreading.
Exactly.
Now, one of the sources talked about the Chandler classification for orbital complications.
Oh, yeah, that's a good one.
What is that exactly? And how does it help us, gauge how serious things are?
That's a great question. And it shows you're thinking like an ophthalmologist prepping for your boards.
Gotta stay sharp.
The Chandler classification, it basically categorizes those orbital complications.
Okay.
It breaks them down into 5 stages.
5 stages. All right, break it down for me.
Stage 1, that's your preseptal cellulitis.
The less serious one, right?
Exactly. It's
Yeah.
limited to the tissues in front of that orbital septum.
Okay. What about stage 2?
That's when you have orbital cellulitis, but no abscess formation. Stage 3, that's where you get that superior abscess.
The one we just talked about.
Exactly.
Okay, and what about the last 2 stages?
Stage 4, that's when you have an orbital abscess.
So that's an abscess within the orbit itself.
Right. Yep, not just beneath the periosteum.
Wow, okay, in stage 5.
Stage 5, that's the most severe. Cavernous sinus thrombosis.
Cavernous sinus thrombosis. Oh, that sounds scary.
It is. It's rare, but it's life-threatening.
What happens in that stage?
You get a blood clot in the cavernous sinus, that big vein at the base of the skull. It can block blood flow and cause all sorts of serious neurological problems.
So the infection starts in the orbit, and then it can potentially spread to the sinuses and even the brain. That's like a domino effect.
Exactly. That's why we got to be so aggressive with orbital cellulitis. Catch it early and treat it fast before it has a chance to cause those serious complications.
This has been super helpful. I'm starting to feel like I can really tackle these orbital cellulitis cases in an exam setting.
That's what we like to hear.
But before we move on, are there any other questions you think the examiner might ask about this case?
Okay, so let's pretend we're in that exam room. Examiner hits you with this case, the child with the red, swollen, bulging eye,
Right.
pain, limited eye movement, the whole 9 yards. And they ask you, what are your immediate differential diagnoses? What are you thinking?
Well, like we talked about, I definitely mentioned preseptal cellulitis.
Good.
But I'd also make it clear that orbital cellulitis seems much more likely, based on how severe everything is and what the CT shows.
Exactly. You want to demonstrate that you're considering the whole picture.
Right. Now, what if they follow up and ask, okay, but how would you confirm your diagnosis? What would I say then?
All right, so here's where you got to show off your knowledge of those key differences.
Okay.
You'd explain that the proptosis, the pain with eye movement, those limited eye movements, all of that really points to orbital cellulitis.
Yeah.
And you can even back up your answer by referencing that table.
The one that compares the two conditions.
That's the one.
And I could also mention that the CT scan showed a soft tissue mass, near the medial rectus.
Exactly. You're really driving home that diagnosis.
Okay, good. Now, let's say the examiner changes gears a bit and asks, how would you manage this patient?
All right, game plan time.
What would my step-by-step approach be?
Well, first things first, you got to make it clear that this kid needs to be hospitalized right away.
Okay.
This is serious stuff.
No messing around. And then what?
We're hitting that infection hard with broad-spectrum IV antibiotics.
Right. To cover those usual suspects, Staph aureus, strep pyogenes, and H. flu, would I need to, name specific antibiotics?
Yeah, they're probably going to want to hear some specifics.
Okay, so I can mention intravenous cefuroxime.
Good choice.
And I'd want to mention those different dosages for kids and adults, which I remember from the sources.
Perfect. Now, let's say we've got the kid admitted they're on those IV antibiotics. What are we monitoring closely?
Okay, well, we talked about visual acuity, extraocular motility,
right,
and optic nerve function.
Why are those so important to monitor?
Well, we're looking for any sign that the infection might be getting worse.
Okay.
Or that there might be complications developing.
Tell me more about the specific things we're watching for.
So, with visual acuity, any decline could mean that the optic nerve is involved, which is a big red flag.
Absolutely. And extraocular motility.
Well, if their eye movements change, that could mean the inflammation is getting worse, or even that an abscess is forming.
Good. And lastly, the optic nerve.
We know that's super vulnerable with orbital cellulitis.
It is.
So we're watching for any sign that it's being compromised, things like vision loss or changes in their visual field.
Right. Those are all signs that we need to step up our game, maybe get more aggressive with treatment.
Now, what if the examiner asks about complications beyond just vision loss? What are some of the other things that could go wrong with orbital cellulitis?
All right, well, this is where that Chandler classification comes in handy.
Okay.
You can explain those different stages, how they show the increasing severity, and highlight those really scary scenarios, like cavernous sinus thrombosis.
Okay, good. Now, what if they throw me a curveball and say, okay, but the patient isn't responding to the initial antibiotics? What do you do next?
Ooh, that's a good one. They're really testing your critical thinking skills here.
So what would I say?
You'd start by reassessing the patient, really thoroughly, looking for any signs of complications, abscesses, optic nerve problems, anything like that.
And then what?
Well, you might need to think about more imaging, maybe another CT scan.
To see if the infection is spread or if anything new has popped up.
Exactly. And depending on what you find, you might adjust those antibiotics, based on culture results or resistance patterns.
Okay.
If you see an abscess, you got to think about surgical drainage.
Right.
And in some cases, you might even consider adding corticosteroids to help with that inflammation and maybe get those antibiotics working better.
So you're basically showing that you're adaptable, that you can think on your feet.
Exactly. Clinical reasoning, that's what they're looking for.
Makes sense. Now, what if they zero in on the imaging and ask, what would make you suspect a superiostele abscess on a CT scan?
Okay, so here's where you got to get specific.
Okay.
You'd want to point out that it usually shows up as a collection of fluid between the bone and the periosteum,
right,
often along that medial orbital wall.
Got it.
And you could even mention that it might have a particular shape, like a lentil or a crescent.
Oh, okay. Interesting.
That helps distinguish it from other fluid collections.
Okay, and what if they follow up with, why is it so important to identify a superiostele abscess?
Well, here you got to emphasize those potential complications.
Right, how it can press on the optic nerve, lead to vision loss,
Exactly.
and how it could erode into the bone or even spread to the brain.
You got it. You're showing that you understand the severity of the situation.
Okay, good. Now let's change gears a bit.
All right, hit me.
The examiner says, this patient also has chronic sinusitis. How would that affect your management?
Oh, that's a great question. It's all about connecting the dots.
Okay, so sinusitis is an infection of the sinuses.
Right.
But how does that tie into orbital cellulitis?
Well, think about the anatomy. The sinuses are actually pretty close to the orbit.
Okay.
So infections in those sinuses, they can actually spread to the orbit and cause orbital cellulitis.
Ah, I see. So if this kid has chronic sinusitis, it means they've had this persistent infection in their sinuses, and that could make them more likely to get orbital cellulitis.
Exactly. And it also means we need to think about a broader range of bacteria when we're choosing those antibiotics.
Okay, so how would we adjust our antibiotic choices in this case?
Good question. If you're worried about that sinusitis, you want to pick antibiotics that not only cover those typical bacteria,
Right.
but also anaerobic bacteria.
Because those are often involved in sinus infections.
That's right.
So what's a good example of an antibiotic that covers anaerobic bacteria?
Metronidazole is a good one.
Metronidazole. Got it. So we'd add that to the cefuroxime we're already giving?
Yep, just to be safe.
This is really starting to feel like a real exam.
It is, right. And you're doing great.
But is there anything else you think they might ask about this case?
You're really thinking like an exam candidate, which is fantastic.
Well, I'm trying to be as prepared as possible.
That's the spirit.
Yeah.
So what other scenarios are running through your head?
Okay, here's one. What if they ask about surgery? Like, when would we actually need to operate on a patient with orbital cellulitis?
That's a great question. And yeah, you'll want to be ready to talk about that. Most of the time, we can manage orbital cellulitis with those IV antibiotics alone.
Okay.
But there are definitely times when surgery is necessary.
So when would that be? Like, what are the red flags that would make you say, okay, we need to go to the OR?
The most common reason is if there's a superior steel or orbital abscess.
All right, those collections of pus we talked about.
Exactly. They can put pressure on the optic nerve, remember?
Yeah.
And often we need to surgically drain them to prevent complications.
Okay, so draining them helps relieve that pressure and lets the antibiotics do their job.
Exactly. Now, are there any other situations where surgery might be on the table?
Let me think.
Well, sometimes the infection can cause really severe proptosis.
Oh, right, that bulging eye.
Uh-huh. And that can actually compromise the blood supply to the eye itself.
That's bad.
Yeah, so in those cases, we might do a procedure called an orbital decompression.
Orbital decompression, what does that involve?
Basically, we remove a small piece of bone from the orbital wall.
To create more space.
Exactly. That relieves the pressure on the eye and everything around it.
Okay, that makes sense. So it sounds like surgery is reserved for those more extreme cases or when there are complications.
Yeah, for the most part.
Now, what about long-term follow-up? What do we need to keep an eye on after a patient recovers from orbital cellulitis?
Another good question. This shows you're thinking about the whole picture, the long-term effects.
Well, we want to make sure they're truly okay. Right.
Absolutely. So after they've recovered, we're going to keep monitoring them for any signs that the infection might come back.
Okay.
Or any lasting damage from that initial infection.
So what are we specifically looking for?
Well, we'll keep checking their vision, make sure there's no lasting impairment. We'll also watch their eye movements, make sure those are okay.
And what about the optic nerve?
Yeah, definitely the optic nerve. We want to make sure there's no sign of any damage there.
Like what kind of damage?
Things like decreased color vision or changes in their visual field.
Right. So we're basically being super vigilant, trying to catch any problems early.
That's the key. Now, are there any things we can recommend to patients to help prevent orbital cellulitis in the future?
Good question. Is there anything they can do?
Well, one of the biggest things is good hygiene.
Okay, that makes sense.
Yeah.
Especially if they have a history of sinusitis, right?
Exactly. Simple things like washing their hands often,
Mm-hmm.
avoiding touching their eyes,
Right.
and keeping their nasal passages clean.
Okay,
Those can really help prevent the spread of bacteria.
makes sense. And I'm guessing vaccinations are important too.
Oh, absolutely. Vaccinations are huge for preventing all sorts of infections, including the ones that can lead to orbital cellulitis.
Wow, this has been so incredibly helpful. I feel like I've learned so much about orbital cellulitis.
I'm glad to hear that.
I feel much more confident about tackling those exam questions now.
That's what we like to hear. And hey, remember, you've put in the time, you've studied hard, you're ready for this.
Thank you. I really appreciate all your insights and guidance. This has been a true deep dive into orbital cellulitis. And to everyone listening, best of luck with your exams.
Absolutely. Best of luck to all of you. And remember, this is just the beginning. Keep learning, keep asking questions, and keep striving to be the best ophthalmologist you can be.
That's a wrap for today's deep dive into orbital cellulitis. We hope you found it informative and helpful. Until next time, keep those brains buzzing, and we'll catch you on the next episode of The Deep Dive.